Sure.
Yes, it's visible.
Sure. So when it comes to clinical trials, we have a sense of fear because reading trials and understanding them becomes a daunting task. So please lose your nervousness today. Listen to me as if you are listening to a story, and I will tell you 5 little stories of how these studies were conducted, what significance it has for neonates, what we can interpret from them. Okay, I shall cover certain topics. One in delivery room about respiratory management in neonates, recent trial with respect to preterm nutrition, developmentally supportive care, and in community. So we all know that in all vigorous babies, delayed cord clamping has become the norm. But babies, when they do not breathe at birth, we clamp the cord immediately because resuscitation or positive pressure ventilation becomes important for them. So for babies who require positive pressure ventilation or they are non-vigorous at birth, currently there is insufficient evidence to recommend whether we should go for early or delayed cord clamping. What are the harms of early cord clamping? Because it interferes with the healthy neonatal transition because most of the blood is left in the placental circulation and there is rather than filling the neonatal volume and the cardiovascular stability may be affected. The European Resuscitation Council recommends considering at least cord milking, umbilical cord milking when delayed cord clamping is not feasible. But we know that umbilical cord milking is not recommended for babies who are less than 28 weeks gestation because of increased risk of intraventricular hemorrhage. So this particular trial published in American Journal of Obstetrics and Gynecology looked at whether what are the pros and cons of early versus delayed cord clamping, early versus umbilical cord milking, in babies who are non-vigorous at birth. Here, we are not including preterm population, but late preterm and term babies. So the title is in non-vigorous, late preterm and term babies, is umbilical cord milking superior to early cord clamping in decreasing neonatal admissions to NICU? So we know that a baby who is non-vigorous is born limp, pale, or has no or minimal breathing. And why umbilical cord milking is because it is relatively quick. And in studies in term infants, umbilical cord milking has been shown to improve the neonatal transition, like improving the heart rate, blood pressure, cerebral oxygenation, better hemoglobin levels, and also to prevent anemia. So when delayed cord clamping is not feasible, why not try and do umbilical cord milking as compared to early cord clamping? So this was a cluster RCT with a crossover design. I'll explain why they chose a cluster RCT. So as we know that these are late preterm and term neonates who are non-vigorous at birth. The mean gestation and the birth weight of babies involved in this trial was 39 weeks and 3.3 kg. And the study was conducted in 10 centers, 7 in the United States, 2 from Canada, and 1 from Poland. So why did they choose a cluster RCT? Because in an individual RCT, individually randomized trial, each and every neonate will have an equal chance of being randomized to either cord milking or early cord clamping. Here, this cord milking or cord clamping, whether to randomize or not, is made at the delivery table when the baby is born, because babies who are non-vigorous only can be randomized. So in such cases, what they did was to randomize these hospitals, these 10 hospitals, 5 into an umbilical cord milking group and 5 hospitals into 5 centers to early cord clamping group for 1 year. At the end of 1 year, they will, whoever has performed umbilical cord milking will do early cord clamping for the next year. So in such a way, that that entire center practices the same intervention for all babies for that particular stipulated period. So what was the primary outcome? The sample size was calculated for the primary outcome. The primary outcome was pre-specified indications for NICU admission. And as a safety outcome, they calculated the incidence of hypoxic ischemic encephalopathy. So this is the figure. So late preterm and term babies, non-vigorous at birth, then they randomized by center. So cord milking or early cord clamping, at the end of that year, that center will cross over to perform the other intervention. So how was cord milking performed? A 20 centimeter length of umbilical cord was milked 4 times. Or early cord clamping, which was cord clamping within 60 seconds. Primary outcome was admission to NICU. And there could be various reasons for admission, which included not only distress, bradycardia, tachycardia, hypotonia, lethargy, hypoglycemia, emesis. So whatever may be. So these are the pre-specified admission criteria. If the baby was admitted for any reason to the NICU, it was taken as an outcome. So this particular trial goes by the name MINVI trial. So when we look at the primary outcome, which is NICU admission, it was need for NICU admission. So it is a dichotomous variable, yes or no variable. So here we calculate the ratio. So when we compare two ratios, the ratio in the cord milking group and the risk of admission in the early cord clamping group. So when we compare, we express the results as a risk ratio or an odds ratio. So here you see the adjusted odds ratio 0.69. But when you look at the 95% confidence interval, it crosses 1, which means that this outcome is not significant. So the NICU admission was 23 and 28%, but this is not significant between the group. The need for cardiorespiratory support, 60% and 71%, the 95% confidence interval does not cross 1. So this is significant. So there is less need for cardiorespiratory support in the cord milking group. So these are the outcomes which are depicted here. The reduced need for NICU admission was not significant, but they noticed that these babies, umbilical cord milking group, had higher hemoglobin levels. The risk for moderate to severe HAE was less in the cord milking group. Need for therapeutic hypothermia was less. The Apgar scores were better. The peak, although there was a slightly higher peak bilirubin levels, but the levels are less, 7.3 and 6.6, so it is not clinically important. So what are the implications from this trial? This is the first of its study to compare umbilical cord milking in non-vigorous neonates. What did they notice? Although there is no difference in the need for NICU admission, some secondary outcomes showed a favorable trend, which include less need for cardiorespiratory support in the milking babies in the delivery room, lesser HIE, and less use of therapeutic hypothermia. Moreover, the particular intervention was found to be safe because we noticed that they had included HIE as a safety outcome. So there was no higher incidence. In fact, it was even lower. So this particular intervention was found to be safe. It may be relevant in low middle income countries, which has a higher incidence of HIE. So these secondary outcomes are only hypothesis generating. So what we have to stick to is a primary outcome for which sample size has been calculated in this study. So we should also look at whether not only is the transition important, we also need to know how long-term these babies are doing, especially the cord milking group. So this particular study is following up these babies to look at the neurodevelopmental outcome at 2 years of age. So this is the first study we had looked at whether umbilical cord milking is superior to early cord clamping in non-vigorous babies. So now we look at oxygen saturation targeting in the delivery room. So we are all aware of the Dawson's nomogram. Do we know how they were derived? So it was from a prospective cohort of 468 infants, but only 39 of them were born less than 32 weeks. But by dictum, we use them. We use these nomograms across all gestational ages. So during that time when the study was conducted, delayed cord clamping was not the norm. Most of these babies received immediate cord clamping, and babies who received resuscitation, supplemental oxygen were excluded from this particular study. So the lower targets, as you see here, they correspond to 25th centile of the nomogram. So they also noticed that preterm babies in effect have a saturation which is 3 to 8% lower compared to term individuals, and babies who are born by cesarean also have a lower saturation to start with and may take time to achieve the normal saturation targets by 10 minutes. So we are not sure whether these saturation targets hold true across all gestational ages, and whether does it hold true when we practice delayed cord clamping. So this particular study by Sanchez et al. Tried to see what are the changes with respect to delayed cord clamping on the oxygen saturation and heart rate patterns in the first few minutes after birth. So this particular study, published in Journal of Pediatrics, looked at SpO2 and heart rate centiles for the first 10 minutes after birth in term infants who undergo delayed cord clamping for at least 30 seconds or more. So the population is term vaginally delivered infants. Mean gestation was 40 weeks, birth weight was 3.3 kg, and the average time that delayed cord clamping was done in the study was 110 seconds. And the time to attach pulse oximeter took a median of 60 seconds. This particular study was done in a single hospital in Spain. So 282 infants were enrolled, and the primary outcome was oxygen saturation and heart rate after birth. So this is the study result, and this particular red line is the current study and superimposed on the Dawson's nomogram. What do we find? When we do delayed cord clamping, the oxygen saturations are higher in the first 3 minutes after birth, and then they plateau and reach the usual Dawson nomogram. Similarly, when we look at the heart rate patterns, what we notice is that these babies have a stable heart rate for the first 10 minutes of life. So this in fact tells us how delayed cord clamping helps in the early stabilization of the babies. They pick up the saturation much early, and they have higher saturation compared to the usual Dawson's nomogram, and the heart rates remain very stable in the first 10 minutes. So what are the implications from this study? So they say that the oxygen saturation nomograms, what we currently use, may see a change in the near future. So it depends not only on the mode of birth, cesarean versus vaginal, but also on the baby's gestation and whether delayed cord clamping has been done or not. Also, we may find some changes when early skin-to-skin care is practiced. We need more information on saturation targets in the resuscitation room for preterm babies and those babies who need resuscitation. In fact, now we are extrapolating these normal nomograms to all gestation and for all babies who need resuscitation also. So there may be a change in the future in the way the saturation targets are being used. That's the implication from this study. Now we'll move on to respiratory support in the NICU. So preterm babies have a higher risk for respiratory distress syndrome, and we give surfactant when we have a high clinical suspicion of respiratory distress syndrome. Babies with onset of respiratory distress immediate or soon after birth, oxygen requirement more than 30% on CPAP. We don't wait for an X-ray, we go ahead and offer surfactant to these babies because early rescue is more beneficial compared to later surfactant. So ensure technique had come about in a big way because rather than continuing mechanical ventilation, putting surfactant extubating to CPAP is much better. Now we have moved on to LISA method, which is less invasive surfactant administration or minimally invasive surfactant administration, where we insert a very thin catheter to the trachea using a laryngoscope while the baby is still on non-invasive respiratory support like CPAP. So this allows babies spontaneous breathing to proceed while also preventing the administration of the positive pressure breaths using the bag and mask or through the endotracheal tube. So LISA has come up in a big way because there is lesser risk of BPD, lesser need for mechanical ventilation when surfactant is delivered to LISA technique. Now, when we talk about LISA technique, two surfactants are commonly used here. Often in the West, the porcine-derived surfactant or the poractant is preferred because the volume of surfactant which is given through this technique is less. There is less of a reflex. However, we do not know whether biractant or the bovine-derived surfactant works as well as the porcine-derived surfactant when used with the LISA technique. So, this particular study from India looked at whether which surfactant, porcine or biractant, is better when we use it for RDS using the LISA technique. So why are we talking about poractant and biractant? What are the basic differences between these surfactants? So one is the phospholipid content. The porcine surfactant has a high concentration, 80 milligram of phospholipid per ml compared to 25 milligram per ml in biractant. So that explains why we use lesser volume of poractant compared to biractant. The other one is poractant has a known quantity of surfactant protein B, which is very important for surfactant distribution and absorption. Whereas the amount of surfactant protein B in the other natural surfactant, which is bovine derived, is not known. So when we do head-to-head comparison from the earlier studies, they said that when you offer a higher volume of poractant, 200 milligram per kg, that works better compared to 100 milligram per kg of biractant. But for subsequent doses, the porcine surfactant dose is only 100 milligram per kg. So using this LISA technique, we don't know which one is superior. So this particular study from West Bengal in a randomized control trial compared the efficacy between biractant and poractant among preterm infants 28 to 33. These are slightly bigger preterm infants with RDS using the LISA technique. So the population, as I said, was 28 to 33 weeks with RDS. Mean gestation in this study was 30 weeks. Weight was 1.4 kilogram. It was an open label RCT, single center in India. 130 neonates were recruited, 65 to each of the two surfactants. And the babies were randomized at 40 minutes of age. The dose of poractant was 200 milligram per kg. Biractant used was 100 milligram per kg. And the primary outcome was need for intubation and mechanical ventilation in the first 72 hours of life. So primary outcome, so it is a dichotomous outcome, right? So need for ventilation or not. So when we compare two dichotomous outcomes between two groups, we calculate what is called as the risk ratio. So as you can see, the need for ventilation was not much different between these two groups. But when we looked at the cost, because poractant was given at a higher dose, when we they looked at the surfactant cost and the total hospital cost, it was much lower in the biractant group. So the strengths and limitations of this study, this is the first study from LMIC setting, which compares head-to-head comparison of two surfactant using less invasive surfactant administration. Study strengths include a homogeneous population of inborn preterm infants from a tertiary center, all managed with the current evidence-based care. What are the drawbacks? They included bigger preterm babies, less than 28 weeks were excluded. Long-term outcomes were not analyzed. They have not looked at the duration of oxygen support or the BPD rates. It was only a short-term outcome. The study was not blinded. They anticipated that 58%, two-thirds of these babies may require mechanical ventilation in the control group based on previous studies. But in this particular study, their rates were low. So this can compromise the power of the study. Why this could compromise the power? Because they calculate the they calculate the sample size based on the primary outcome. When the event rate of the primary outcome, baseline event rate is high, then you need less of a sample. But in the actual study, when they find the event rates to be very less, they should have recruited more babies to answer or find out the difference. So that's why it compromises the power of the study here. So what are the implications? So it seems that because the primary outcome was not much different, the bovine surfactant could also be given by the LISA technique. And in the study, they used the feeding tube and not the specialized catheter. So that requires a little bit of more practice to use the feeding tube. But we need larger RCTs to look at BPD and other long-term outcomes. So now we move on to the next study. I'll take up questions at the end of the presentation. So we'll keep moving. So now we'll look at the nutrition. So what do we know first? So first choice of preterm nutrition is mother's own milk, especially for preterm babies or low birth weight, very low birth weight babies. So this is from the recent WHO recommendations on care of preterm or low birth weight infants. There is a very strong recommendation that mother's own milk is a preferred milk. If when mother's own milk is not available, next choice is donor, pasteurized donor human milk. If that is also not available, then nutrient-enriched preterm formula may be considered. Okay. So this is a conditional recommendation. So now the question is donor human milk superior to preterm formula in improving neurodevelopmental outcomes at 24 months? So now it is looking at neurodevelopmental outcomes. So when mother's own milk is not available, if we can prove that donor human milk improves long-term neurodevelopmental outcomes, then there would be a sea change in establishing milk banks and providing each and every baby with donor human milk when mother's milk is not available rather than give formula. So that is why this particular study was designed. So mother's milk has better neurodevelopmental outcomes than formula. No RCTs can be conducted and it's unethical to study. But we know that there is a clear dose-response relationship between mother's milk intake and higher neurodevelopmental scores at 18 to 30 months. But is it true for donor human milk also? We didn't have any evidence till then. This particular study tries to answer that question. So this is called as the milk trial, the neurodevelopmental outcomes of extremely preterm infants fed donor milk or preterm formula. So this particular study was published in JAMA. The question is, among preterm infants who are fed minimal maternal milk when mother's own milk is insufficient, does feeding of donor milk compared to preterm formula during birth hospitalization result in improved neurodevelopmental outcomes? So this is a long duration study and they are looking at neurodevelopmental outcomes at around 20 months of age. So population is extremely preterm, less than 29 weeks or less than 1000 grams. The median gestation of the babies in this particular study was 26 weeks. Birth weight was 840 grams. This was done in 15 academic centers in the USA. So they randomized 483 babies, 239 to the nutrient fortified donor milk and 244 to the preterm formula group. The primary outcome was Bailey scale of infant development 3, done at 22 to 26 months corrected age. So, the study results. The primary outcome was mean BSID cognitive score. BSID 3 cognitive score. Because we are comparing means between two groups, we would be expressing it as mean difference. So remember, when we are calculating the risks in dichotomous variables between two groups, we calculated either odds ratio or risk ratio. Here, the outcome is a mean. So when we compare two means, we calculate the mean difference and express with 95% confidence interval. So in the donor milk group, the cognitive score was 80.7 with standard deviation of 70. In the formula group, it was 81. When we look at the 95% confidence interval, what do we see? It crosses 0. And although it was minus 0.77, it crosses 0, which means there is no difference between donor milk and the formula. They also looked at the other scales, language and motor scales. There was no difference. Mortality was also not different. When they looked at NEC rates, there was significant difference. In the donor milk group, it was 4.2%. In the formula, it was 9%. Donor milk had lower, very low incidence of NEC. So what are the practice implications? Donor milk definitely decreases the risk of NEC, which is a very important outcome for extremely preterm babies. As the study started rolling, they noticed very good changes. So at the study initiation, only 25% centers of the 15 academic centers, only 1/4 of them had used pasteurized human donor milk. But by the end, 75% were using it. And so the study had to close early because recruitment was not possible, because they started seeing a positive change in most units with higher pasteurized donor human milk use. The donor milk was fortified in this particular study to provide higher protein using commercially available fortifiers or protein supplements. The weight gain in the donor milk group and the formula group was only 2 grams different, not very much. And the other things was, it was a pragmatic study. So what is a pragmatic study? The study, they define what should be the one change that has to be different for both the groups. For example, they mentioned that if the mother's milk is insufficient, they could randomize that baby to donor milk or formula. What they didn't specify was when feed has to be initiated, how much increment has to be used, how much fortifier has to be used, how long has the fortifier been given. All these were left to the individual centers to practice. So this particular use of a pragmatic thing helps because it resembles the day-to-day practice. So this is an example of a pragmatic study. So there are some drawbacks also. One, because the study is close to recruitment early, sufficient numbers could not be recruited to adequate sample size could not be achieved. And there was a huge time interval between to study enrollment. They could be randomized at any time between first and 21 days. And by the time of discharge, even babies who are on donor milk could be transitioned to formula. So neurodevelopmental outcome is not only dependent on the early feeding, but also the later feeds would also matter. So this is one drawback of this particular study. So as you can see, over the period of time from 2000 to 2022, there is an exponential increase in donor human milk usage in the United States. So that's an important thing, and rather than debate whether donor milk improves neurodevelopmental outcome or not, definitely decreases the risk of NEC. So it's definitely beneficial and has to be encouraged in the NICU. So now we will move on to developmentally supportive care. So currently for developmentally supportive care, we use nesting in the NICU. But often many of these babies suffer from plagiocephaly, which is asymmetrical flattening of the skull bones because of their prolonged positioning. So 38% of preterm babies have deformational plagiocephaly at term equivalent age. When it is very severe, often Western countries use a helmet to shapen the head. But are there other interventions to prevent plagiocephaly? That's what this particular study from India, from CMC Velo, tried to answer. So mustard seed pillows are easily available. They are cost effective, traditionally used to position infants, especially in northern India. These seed pillows can mold to the shape of infant's head and shoulder. They equalize pressure on the cranium and allow symmetric positioning without much restriction. So it was a randomized trial enrolling preterm babies less than 32 weeks or less than 1500 grams. So one group received just nesting. The other group, in addition to nesting, was given a mustard pillow. And because the intervention was visible to everyone, it was an open label RCT from a single center. The primary outcome was deformational plagiocephaly. They used various parameters like the cranial index, the cranial vault asymmetry index, and visual assessment at 4 weeks, and also looked at the motor development in these babies. So this is the orange ones are the intervention group, blue is the control. So compared to week 1, in week 4, the cranial vault asymmetry index in the mustard pillow group was significantly decreased, which is an important thing. But what they noticed was the brachycephaly was still present. There was no difference. So although it may decrease the plagiocephaly, deformational plagiocephaly, some of these infants still had some the brachycephaly, and the motor performance was not different at the time of discharge. So practice implications: mustard pillow supports head, neck, and shoulders, facilitating flexion and midline positioning, and can decrease the incidence of plagiocephaly. It's easily available and a cost-effective intervention. The limitation of this study was that because it was an open label, the outcome assessor was not blinded to the group allocation. And there was only a single assessor who could do all these measurements. So they could not measure inter-observer variability. And not only discharge assessment, we need to have continued assessment at 3 months and at 6 months to see whether the plagiocephaly improves or persists. So some long-term assessment could have been much better in this particular study. But it offers hope to decrease the plagiocephaly even in the NICU during care. So these are the two sizes of mustard pillow that they had used in this study. Now the final study, we'll look at a community study. It's a very large study done in India in the community setting and addresses a very important problem that we face. So the National Family Health Survey 5 data shows that the low birth weight prevalence in India is around 20%. Our rates of low birth weight, rates of small for gestational age is pretty higher compared to the Western data. And when we look at the under 5 children nutritional status, we have 2/3 of them having anemia, 1/3 of them having stunting, 20% have wasting, and 10%, less than 10% are severely wasted. So usual interventions to decrease the growth faltering in under 5 children have usually focused on educating about complementary feeding and iron folic acid supplementation for mothers during infancy. But are there any additional intervention which can tackle low birth weight, which can tackle the nutritional outcomes in under 5 children? That's what this particular study in the community had focused at. So this is the WINGS randomized clinical trial. the Women and Infant Intervention Group study published in the BMJ. It is from India, from the northern India, and they delivered a package of interventions during the preconception, during pregnancy, and in the early childhood period to look at the birth outcomes and the linear growth outcomes at 24 months of age. It is a factorial, individually randomized trial. The first trial we saw was a hospital-based study, but it was a cluster randomized study. So when we usually look at community studies, they are usually cluster randomized, but this study in the community was individually randomized. And because interventions could be delivered during any of these periods, pregnancy, preconception, or early childhood, it was a factorial design. So what does this study question, what is the study question? Does a package of multimodal interventions addressing health. So the interventions are not single. It is a multimodal intervention. It addresses health, nutrition, pregnancy care and support, environmental hygiene, delivered during 3 periods: preconception, pregnancy, early childhood. 2 outcomes, birth outcomes, as well as the linear growth, birth outcomes and linear growth at 2 years. So the population is married women 18 to 30 years with no or one child. Individually randomized factorial design, low middle income neighborhoods of Delhi, and they randomized 13,500 women to either of these groups, preconception or the control group. When the intervention was delivered, preconception, around 6,000 had that preconception intervention, the other formed a control. Then these women underwent a second randomization that we will see later. And these are the interventions here. So here we see the interventions. The interventions are nutrition, psychosocial support, and the wash, sanitation, hygiene. So let's take the preconception period. For health, what did they do? They screened these women and treated them for medical condition. For nutrition, they provided iron, folic acid, and if they had a BMI less than 21, they provided additional nutrition in the form of egg or milk. Screened them for malnutrition, treated their anemia. Psychosocial support, positive thinking, problem-solving skills. And for wash, hygiene, and they promoted personal, menstrual, and hand hygiene. During pregnancy, they screened. This is an 8-visit model, 8 antenatal visit, screen and treat for medical complications during pregnancy, supplement iron, calcium, hypothyroidism, diagnose and treat UTI, reproductive tract infection. For nutrition, they provided iron, folate, and also additional nutrition with higher calories and proteins, as well as milk if the body mass index was less. Again, for wash interventions, they were provided with water filters, soap, hand washing station, disinfectant. Early childhood, they offered lactational support till the 6 months, and after 6 months, complementary feeding, and as well as supplementary feeding with calories and proteins. And if there was inadequate weight gain, these are for children. So they provided double supplement. Promote early child play and responsive care. They were provided with a mat and a play mat and a potty. Postnatal for the mother, 6 postnatal visits, additional continued calcium and vitamin D, and as well as additional nutrition for these mothers. So these are the intervention. Interventions are in 3 different periods, and it is multimodal: nutrition, positive health, nutrition, and the sanitation, as well as psychosocial support. So it is a multimodal intervention and different periods. So the initial randomization, preconception or no preconception intervention. If pregnancy is confirmed, then they underwent a second randomization to provide interventions during the period. So if you look at the final thing, the mother can have only preconception. One group will have only preconception intervention. Group 2 will have preconception and pregnancy intervention. Third group will have preconception, pregnancy, early childhood intervention, all given. And fourth control group will have no intervention. So what are the outcomes? First is the incidence of low birth weight. The incidence rate ratio was 0.85, 95% confidence interval 0.75 to 0.97. So this is significant. So there was a lower incidence of low birth weight. The risk reduced to 24%. Reduced the risk of low birth weight by 24% when you give both, and the reduction was much higher when the intervention was given in the preconception and pregnancy. When we look at the linear growth at 2 years, the risk of stunting at 2 years was reduced by 51%, and most of it could be attributed to interventions during pregnancy and early childhood. Okay, during early pregnancy and childhood. So they also noted additional maternal benefits because of these. Mothers had higher hemoglobin, gestational weight gain was higher, lesser risk of reproductive tract infection, anemia, and PIH. What are the strengths of the study? Rigorous study design. It's not a small feat to conduct such a large study to recruit 13,000 women to deliver interventions in 3 different periods, multimodal intervention. There was a high compliance for most of these interventions, and the outcome measure was well standardized. And these outcome measures are very meaningful compared to the smaller studies which had looked at the need for ventilation or failure rates or cardiorespiratory transition at birth. The incidence of low birth weight, the reduction in stunting, they have real meaning. So they are important clinical outcome measures for any study. So the outcome measures were very well standardized. Early pregnancy ultrasound based gestational assessment was done, and it's generalizable to low middle income countries in urban populations. So the challenge here is how to implement it at a large scale. So when it is as a part of a study, then things get implemented. But on a normal day-to-day practice, these interventions have to be embedded in the existing programs. For example, the family planning, it comes under the RMNCHA, the program which is already running, and iron folic acid supplementation is a part of Anemia Mukt Bharat. Supplementary nutrition for the women and children is through the ICDS. Iron folic acid supplementation for 180 days, again for women through the Anemia Mukt Bharat program. Calcium, vitamin D supplementation, national guidelines for calcium supplementation during pregnancy, lactation. So it's all delivered through the Anganwadi centers, the dispensaries, and the home visits for newborn is through the home-based newborn care. The ICDS program supplements the complementary feeding, immunization, and other things. So programs do exist. How to deliver them to reach the beneficiaries also exist, but it has to be of high quality. These interventions, coverage as well as quality, need to be taken care of. So the implications, while most interventions provided during pregnancy and early childhood are part of several national programs, they need to be of very high quality. We need research to focus on how to implement these interventions within the routine system to improve adverse growth outcomes like stunting. The study also looked at neurodevelopmental outcomes in a sample of children at 2 years corrected age. They also noticed improvement in Bailey score as well as lower incidence of moderate to severe neurodevelopmental delay in cognitive, language, and socio-emotional domains. So it also improves not only linear growth or low birth weight. These interventions, holistic intervention, also improves neurodevelopmental outcome at 2 years corrected age. So what did we learn today? So we looked at a couple of trials, recent ones, and we have some important learnings from these trials. We noticed that in babies who are who need immediate resuscitation, who are not vigorous at birth, Umbilical cord milking seems feasible. Only thing is that this particular study has been done in late preterm and term infants, so that may be the suitable population. We have more knowledge now that the oxygen saturation targets, one size may not fit all. In the era of delayed cord clamping, these babies achieve the saturation targets much early with a higher saturation. When you are offering Lisa, Bractant also seems to work as well as the Poractant with much reduced cost and no difference in the rate of mechanical ventilation. Pasteurized donor human milk reduces the risk of NEC and has to be promoted, although study did not show any change in the neurodevelopmental outcomes. Mustard pillows may gain entry to the NICU as a part of neurodevelopmental developmentally supportive care because they may decrease the incidence of the plagiocephaly. A multimodal intervention offered in preconception, pregnancy, early childhood period may influence a public health policy in the near future. So these are the learnings from the studies that I presented today. If you have any questions, I shall be happy to answer.
Thank you so much, ma'am. So we are in for question and answer session. So any queries, please put it in the chat box.